Okay, well, I think people will join as we go along, but it's my pleasure and privilege to introduce Dr. Rina Khanna to give us a talk today to present rounds. I have to start by saying the rounds are being sponsored by BioJamp, which are the makers of Simlandi, which is a Humira biosimilar. So I thank you for that sponsorship to enable Dr. Khanna to give us rounds today. As many of us gastroenterologists know, Dr. Khanna is an associate professor of medicine at Western. She's a clinical researcher in the program for experimental medicine. She completed her MD in internal medicine at University of Western Ontario. Her gastroenterology fellowship was at McMaster. She completed an advanced fellowship in inflammatory bowel disease at the Cleveland Clinic, followed by a research fellowship in international IBD clinical trials at University of Western Ontario. She completed her Master's of Science in Clinical Epidemiology at McMaster. Her clinical and research interests are clinical trial design, new therapeutics, outcome measures, and others. She's received international grants, has been a speaker at a number of events, and has been awarded the Crohn's and Colitis Canada's Rising Star Award for her research contribution. So we're very honored and privileged, and thank you, Dr. Khanna, and I leave the floor to you.
So thank you very much for that warm introduction. Thank you everybody for joining me today. It is my absolute pleasure to be able to speak about anything IBD related. It's kind of what I live and breathe. So I'm going to be talking about a very specific area. We're going to talk about TNF antagonists. And we all know these were our very first medications and really have been the bedrock of IBD. And so there's two aspects of this. One is with the advent of the biosimilars. What does that mean? And more importantly, where is their role? So we've been so blessed in the IBD space to have so many new molecules. One that was Health Canada approved just 2 weeks ago. And so now with a lot of these newer medications, there's more question around where the TNFs actually fit in. So that's really what I'm going to focus on today. I will just point out these rounds are being sponsored by BioJamp. I actually declined the honorarium just because I wanted to be able to speak with you guys very candidly about what I believe. So just keep that in mind. These are completely my beliefs. So these are my conflicts of interest that I'm hoping to disclose to you now. Now, in terms of new molecules that have been approved, there are just so many in the last little while that we've seen in the IBD space. So ozanimod, which is an S1P1 inhibitor, was approved in the spring. It was a very silent launch. I think many people didn't even realize the molecule had launched, but it is available for use. Ozanimod we may be familiar with from the multiple sclerosis space. So its mechanism of action is it blocks activated lymphocytes within lymph nodes, and so it does lead to a lymphopenia. It does require more monitoring than most of our typical medications. It's an oral small molecule. However, there has been association with macular edema, certain cardiovascular outcomes. There are receptors in the SA nodes. There's a requirement for an ECG. So I have to say this medication just comes with a bit more monitoring than we've typically seen in the IBD space. There's a lot of excitement around risankizumab or Skyrizi. This is an IL-23 agent that was just received its Health Canada approval 2 weeks ago. We expect the first dose to be infused in Canada on December 12th, to be exact. This is in the same family as Stelara loosely. It does have some overlap in mechanism. We often borrow drugs. It's a new drug that's not a new drug. It's been used in psoriasis now for quite some time. The dermatologists tell us that this is the most effective agent they've ever had for psoriasis. And we're based on the phase 3 trials in inflammatory bowel disease, we're really hoping that this molecule is going to break some of the efficacy barriers in IBD. And there's a lot of excitement around having a new class of therapies to use altogether. And certainly there are many other agents that are in the pipeline. The one that's probably closest to coming to our clinics is upadacitinib. For ulcerative colitis, we expect the NOC from Health Canada any day now. And for those of you who are following the literature, upadacitinib is a JAK1 selective agent. So for those who are following the IBD space, JAK inhibitors, we have one, tofacitinib or Xeljanz, which is a pan-JAK inhibitor. This is specific to JAK1, which is the immune IBD pathway. And our hope is that we would prevent some of the toxicities associated with JAK inhibition, which include venous thromboembolism, increase in the lipid profiles, elevation in CK, malignancy. So a number of the adverse events we hope will disappear with these JAK1 selected agents. So all of the new agents really are boasting greater efficacy than we've seen previously in the IBD space, and many of them are talking about greater safety, so that we're improving safety while not compromising and, if anything, expanding on efficacy. So with this lens, there's been a lot of thought as to where is the role of TNF antagonists? Like, do they still serve a purpose? And so that's really what I was hoping to discuss today, is where that role of TNFs are. Now, in the IBD space, and I have a very specific clinic, we still have a very limited number of options. And I think all of these agents are going to have a role. And I do still think there is a role for TNF inhibition. TNF antagonists, and we'll talk about this a little later, are a little downstream in terms of where the inhibition happens. But TNF is so ubiquitous that it's actually considered fairly broad immunosuppression. And when we look at agents that might be more targeted in their immunosuppression, there's some question regarding where these agents will still fit in. And there are people who will get up on and speak and will actually say that there is no role and that we should be using these newer agents. And I don't think that's entirely the case. So we'll hear a lot about biosimilars, and I'm not really planning to speak much to them. We know that there are many of the originator TNF antagonists have come off patent, and so there are biosimilars. I'm sure you're all very familiar with this concept, but biosimilars are essentially like generics. We don't call them generic though, because to be a generic is a very specific term. And so generics are usually reserved for chemical structures, small molecules, and those chemical structures, small molecules, can be replicated exactly. The problems with our drugs and with biologic drugs is they're actually proteins. And so you can mimic the amino acid sequence, but there's no way to 100% mimic quaternary folding, and more so those methylation and phosphorylation bonds between the different amino acids. So they are similar. We don't say that they are identical. So they're biosimilars. Now, the reason they get so much buzz and so much traction in the IBD space is because very often they are much so a lot of the original R&D that went into developing the drug is not required because we're using that amino acid backbone. And usually the originator molecule does several very large studies in every disease space in order to get those indications. Health Canada, EMA, FDA have been allowing biosimilar approval by extrapolation. So very often there's maybe 1 or 2 large trials, and then we extrapolate, and if it works in that indication, the biosimilar is usually granted approval in all indications. Now, the reason why this is a bit disappointing in IBD is typically we've seen those trials done in psoriasis or rheumatologic diseases, and I think that's intentional for 2 reasons. One, those diseases are a lot easier to study, in our opinion, because it's much easier to look at skin than to actually have people do scopes repeatedly in order to look at the bowel. And 2, IBD is notoriously very refractory to treatment. And so if you are looking to show a treatment effect, usually it's not going to be IBD that's going to give you a robust treatment effect. So originally when the biosimilars came out, there was a lot of skepticism in the gastrointestinal world where we were almost demanding studies in our disease. We've seen there's lots of drugs that work in derm and rheum that don't overlap to IBD. It's very refractory disease to treat. And so people were really wondering about what that would look like. Since then, we've seen several provinces, particularly notably out west, where they've done this non-medical switch, meaning all patients had to switch drugs, and we really haven't seen a lot of adverse effects. We've all been exposed, had patients exposed to biosimilars, And certainly they do seem to respond to it very well. And in Europe, there were many, many countries that wholesale switched over to a biosimilar, and certainly those patients continue to do well. And so there's lots of real world evidence that now tells us these agents are safe and effective in our IBD patients. Now, the reason for them being incorporated is really to create a bit of a market space. And because some of those R&D costs are saved, it is supposed to be cheaper for our overall system. Ideally, those cost savings would be reinvested so that more patients can receive therapy or to other parts of our healthcare system. And so I'm not going to speak a lot to the biosimilars. I think we can safe to say that there was a lot of skepticism, which no longer exists, and that they are here, and we are using them very well. Now, there's for adalimumab, there seems to be a new biosimilar every week, and so they all have slightly different properties. Essentially, it comes down to differences in the excipients or the needle gauge, or whether they have citrate or not. So just little differences in how easy it is for the patient to maybe inject, but safety and efficacy we think would be very similar for all of these agents. So what we're really talking about today is, where do we use TNF antagonists? So typically that's all we had. For many, many, many years, we only had two drugs, Remicade and Humira. And so we're very used to using TNFs first line because it was the only line therapy that we had for a long time. Now there's all these other agents that have hit the market, and we use other agents sometimes first line. And so sequencing from a TNF antagonist to another agent is something we have a lot of clinical experience with. Going the other way, starting with a different agent, say ustekinumab or Entyvio, and then switching to a TNF, there's less data on that, just because the bulk of our patients would have been on TNFs when these newer agents came out. So there's a fair amount of data, not to say that it's the right way to sequence, it's just that is where the preponderance of data actually lies. So today I'm going to talk a little bit about why people maybe question whether we should still be using TNFs first line, and why there is still a role, in my opinion, for these agents. Now, one of the things that I mentioned is there is this thought that these agents do have fairly broad action. So if I take you way back to your days of immunology, there are several different immune pathways: Th1, Th2, Th17, T regulatory. But TNF-alpha is a downstream product of virtually all our immune pathways, not so much Treg, but of the other three immune pathways. And so effectively, you end up in some way, shape, or form affecting downstream signaling of many different immune cascades. And for this reason, there is some concern regarding a potential adverse effects. And so the adverse effects people worry about often are infection, malignancy, opportunistic infections, demyelination, drug-induced lupus, and all of these certainly occur. I will say these drugs have been used in millions of patients, 9 different indications. It's been used globally. We've used them in pregnancy. We've used them over the long haul for pediatric patients who are on for 20 or 30 years. And although these risks certainly do exist, I think they are much lower than were initially anticipated. And I think we have really good data on how frequently these adverse events actually occur. And in total, the risk-benefit ratio certainly in the majority of patients would still favor their use. So in terms of the off-target side effects, so this was where I was going to remind you. So we think there's some sort of bacterial pathogen that stimulates naive T cells and other immune cells down different pathways. This is there's the Th1, Th2, Th17, and Treg. And if you look at the downstream signaling, TNF really figures into many different pathways and at many different steps. And so there's even local signaling at the tissue level. And so even though it's downstream from where some of our other molecules will target, as an example, ustekinumab targets IL-12 and IL-23, which is far upstream. We actually see less immunosuppression with that agent, only because TNF is so ubiquitous, which I think speaks to why we've had a difficult time finding drug targets in IBD, just because the immune system is so intertwined that sometimes it's difficult to know when you inhibit one thing, you may actually have broader immunosuppression than inhibiting something that's upstream from there. So we see TNF in several different places in this pathway, and this is why it's considered fairly broad immunosuppression. So I think in terms of why we would people maybe argue against these agents again is because of that very broad immunosuppression. There are emerging data that we can look at. So in terms of excess mortality, we do know that these agents have never been implicated in increasing mortality. In fact, active disease and the use of prednisone and narcotics are much more associated with mortality in IBD than any of our biologic agents. So certainly we're not seeing that. And these are the data that show us that active disease, prednisone use, narcotic use are really where we see the bulk of serious infections and malignancy. And so we don't see a lot of that. We don't see a lot of that with our biologic drugs. And then in terms of malignancy, this is a really busy slide and we weren't really going to spend a lot of time. We know that TNF antagonists, really the risk of malignancy seems to be fairly low. And we have to remember that although there are malignancies associated with TNF inhibition, there's also risk of not treating the bowel and risks of certain bowel cancers. And overall, that risk-benefit ratio is felt to be favorable for their use. And then this is our first head-to-head study in the IBD space, something called Varsity. They took patients with active ulcerative colitis and they compared using adalimumab versus vedolizumab, and they found benefit of vedolizumab over adalimumab. And so there was more calls to say that we have safer, more effective agents, and we really shouldn't be using adalimumab. I'm just going to highlight that this study, I am a trialist, and this study was highly, highly faulted. There's so many areas of concern in this study. So it's hard to know if these data are true, but I think we're starting to hear a lot of people say that TNF should not be used, that it should not be standard of care. And I think I just really wanted to highlight that I don't necessarily agree. I think there's a lot of places where TNFs are still really beneficial. Now, I'm also just going to remind you that there's so many levels of evidence, right? And a lot of what we're talking about today is really not going to be in that high quality evidence. It's going to come from real world data, experience cohorts, and there isn't really great data necessarily to help us understand what the optimal agent is in the IBD space. And in truth, I'm not sure there is an optimal agent in the IBD space. What we know, there are several different immune pathways that can lead to IBD. And I think it's really a matter of finding the right pathway that is active in your particular patient. And so I just actually got back yesterday from Copenhagen, where I was attending a meeting. This is one of my areas of research and interest, and is how do we actually target the right drug for the immune pathway that is active in any particular patient. So there's a lot of talk about the randomized controlled trials, which are wonderful. And there's a lot of these network meta-analyses and meta-analyses we'll see. They're a little challenging in IBD because we don't have a lot of head-to-head direct comparisons. We actually only have two, one in ulcerative colitis and one in Crohn's. And so it usually isn't considered a robust network and meta-analysis unless you have multiple direct comparisons. So the level of evidence that we're speaking about today is maybe a bit lower on this totem pole, but it is what we actually have available to us. Now, this is an experience that we all have. So we all have patients. And for those of you who don't practice in the IBD space, if you start at the bottom corner there, where it says 3, that is very severe disease with ulcerations, a very angry looking colon. And we've all had patients who go on TNF antagonists and actually have complete healing of their bowel and go down to a 0, that normal. And so we all know that these drugs do work, and we've all had patients who were saved from colectomy by being on these therapies. And so when we're picking among all of these agents that we have available to us, there are several different factors, and these are actually survey data from Canadian gastroenterologists. And these are the factors that I guess we put into when thinking about which biologic to use for a patient. So we want patients to get better quickly. So we need something that works quickly. We need something that's going to actually have durability. So not not only do they get better, but we want them to stay better for a long period of time. We want to be able to tell that they're actually getting better. So we want there to be biomarkers like calprotectin or CRP that help us gauge whether the drug is working. We'd like something that's safe. IBD disproportionately affects young patients who may require therapies for many years, and we want to make sure that they're safe. We want something that's going to heal the bowel. So we want that mucosal healing. We do prefer drugs that do not have immunogenicity. So I mentioned earlier that these drugs are all by proteins. And so one of the risks is that our body can mistake these drugs for being bacteria or some sort of pathogen and can actually form antibodies against the drug, which prevent them from working. And so ideally drugs that have low immunogenicity. And so with time, we've seen our newer biologics are much less immunogenic than the older biologics, partially due to how they are manufactured, the actual process, but partially also due to the science and when they're actually picking. Usually they develop several molecules and then they pick the agent with the least immunogenic profile. We want to be able to dose optimize and find the optimal dose for any patients. Ideally, we want to be able to impact all aspects of the disease, including some of the extraintestinal manifestations of IBD. And then the mode of administration can be helpful for some patients as well as time on market. And so why is time on market actually helpful? It's how we learn about a drug. And I do have a slide a little bit later on. The longer a drug is on the market, the more we actually learn about it in terms of how to use it and how to use it in patient populations that are excluded from the trials. So I think TNFs still have a very large role in several different areas. And so I think these are the top 7 areas where I think the strongest data are for still using TNFs. There are many other areas, but I'm just going to highlight data in these few spaces where I think they're really highlights that TNFs still have a role in a large number of our patients. So one of the things I'll talk about to start with are fistulas. So for those of you who have ever managed patients with IBD, those of you who've seen patients with fistula, these are connections. So this is supposed to be the rectum. These are the gluteal cheeks, and these green things are supposed to be fistula tracts. There's different fistula tracts. Now fistulas are one of the most recalcitrant parts of IBD. They're very, very challenging to treat. And they're one of the things that affect patients' quality of life more than anything else. So I think fistula tracts really do bother patients. You can imagine there's no sphincter, and so they're constantly pouring out stool, which can become infected. But also there's an issue with odor, hygiene, body image. And so these are really, really challenging to treat. And unfortunately, most of our drugs are not very effective at treating them. Now, there are data to suggest how we should be managing. And so this just shows you, usually when something's this complex, it means we're really not that good at managing the disease. But really, TNF antagonists really fall into almost all algorithms. And there is the only biologic agent that has a dedicated randomized control trial is infliximab. And we apply that, we extrapolate to the entire class, but TNF antagonists actually have a dedicated randomized control trial that suggests that TNF antagonists are beneficial in the treatment of fistula. Now, those data are very old, and I think most of us now would use imaging, like an MRI, to ensure healing. In those days, it was really done based on clinical symptoms and something called the push test, where you literally poked at a fistula and saw if it produced pus. But irrespective of the endpoint, it is really the only randomized data we have. For all other agents, it's usually small subsets of the original clinical trial population or real world data that evolve after the drug has hit the market. So if you're taking a strict data standpoint, certainly TNF antagonists feature into many of these different guidelines. And so these are, just to bring it closer to home, there are a Toronto consensus, which again highlights the use of TNFs in several different places. And so usually first line therapy with patients with very severe fistulizing disease still really comes to TNF, because this is where the strongest data for use really lie. So where's another place that we use TNF antagonists and the data seem to be strongest is acute severe ulcerative colitis. So these are our sick hospitalized patients who we really worry about. I'm going to just remind you that acute severe UC actually is a medical emergency. And so we know that prior to having steroids, up to 50% of patients would actually have mortality associated with acute severe UC. It's very, very unusual for us in the IBD space to be talking about mortality. Fortunately, this is not a common occurrence. And I think now that we have such effective therapies, we sometimes forget how sick these patients really are. But this is a highly risky situation where patients are almost toxic from how much inflammation is in their colon. And so there are data. So this is randomized controlled data, which suggests that infliximab was better than placebo. Now, these patients still receive steroid, but certainly infliximab was safe and effective option in these extremely sick patients. And so this is the only agent that actually has randomized control data. And so all guidelines for acute severe ulcerative colitis will suggest infliximab. So we know these patients, there's a very clear algorithm. They get admitted to hospital. We rule out infections. They're started on steroids. And if not better, by day 3 to 5, we need to either consider colectomy or salvage therapy. Our options for salvage are cyclosporin or infliximab. The problem with cyclosporin being that it can't be continued in the long haul, whereas infliximab can be continued as maintenance therapy. Now, you'll hear at the meetings where people talk about possibly using tofacitinib or some of these other agents. It is not based on randomized controlled data. It's considered off-label and certainly does not have a guideline and randomized controlled data to support its use. And so we know infliximab has salvaged many patients from having colectomy and can then be carried on to be used. And so still, this is just one guideline, which still recommends using TNF antagonists in these very, very sick patients. Now, another place to consider using TNF still is in the post-operative setting. So we know patients who have surgery in IBD, not so much colectomy, more so in Crohn's disease, where there's a segmental resection. We know that having one surgery puts people at risk for having subsequent surgery. And so really our goal post-operatively is to prevent disease recurrence and to prevent further surgeries from actually being required. At some point, if you imagine if someone is diagnosed in the pediatric age group and every 5 years has resection, we worry that at some point there may not be enough gut remaining for adequate nutrient absorption, and certainly surgery itself is associated with certain morbidity as well. And so in terms of agents, again, TNF antagonists are the only agents with a dedicated randomized controlled trial. Now, it was negative for the primary outcome, but the secondary outcome of endoscopic recurrence was much lower with infliximab compared to placebo. Now, I know people will talk, why would you compare it to placebo? But I think at the time that was a standard of care, that patients didn't necessarily weren't necessarily put on therapy unless they actually had unless they had symptoms, and we now know symptoms are a late finding. So certainly if you're looking at data, the only randomized controlled data would suggest the use of a TNF antagonist. Now, is this the only agent I ever use? No, there are patients who have failed TNF antagonists and then go on to have surgery. And in those cases, if I really think it's a failure of drug, not that the drug was started too late, we sometimes will try a different mechanism of action. I will remind everyone that post-op is a high-risk state, and it's also a place where we can really intervene and help patients a great deal. And so I'll just remind you that our guidelines suggest that the algorithm now is stratifying patients and deciding whether we think they're high risk, intermediate, or low risk. The low-risk patients, they say, can either be put on nothing or maybe antibiotics or maybe even a 5-ASA. It might be one of the few places to use 5-ASA in Crohn's. Patients who are high risk, we want to put right onto a biologic, and those intermediate risk group, you may consider a small molecule immunosuppressant like Imuran or methotrexate. Irrespective of what we try, they say within 3 to 6 months, we really want to scope them and see if there's ulcers at the anastomosis. And this comes from very, very clear data, which tells us that patients will form ulcers first, then they'll get biomarker changes, and then they'll develop symptoms. So if we wait for our patients to become symptomatic, we'll have waited too long. We really want to nip the disease in the bud and prevent stricturing and complications. We know that ulcers in the neo-terminal ileum, so the new ileum, are more predictive of having disease recurrence. Ulcers at the anastomosis are much more predictive of stricturing disease. So even where those ulcers are can be really helpful for us when determining what we want to do in terms of next steps. So the other point I'll raise is I think we've learned a lot that symptoms overall in Crohn's disease really are not adequate. And so as a field, we really turned towards moving towards using these objective markers. When two tests are 100% correlated with each other, we say the correlation coefficient is 1. So that's perfectly aligned with each other. Symptoms and endoscopy in IBD have a correlation coefficient of 0.4. I shouldn't say with IBD, with Crohn's disease. And so 0.4 is worse than flipping a coin. So certainly we can't rely only on symptoms in these patients. And this is why we've turned to endoscopic assessment. And based on endoscopic data, TNF antagonists are really the only agents with a dedicated trial. So does this mean that the other agents don't work? Absolutely not. We can't say that at all. We just don't have randomized controlled data to support their use. I certainly have used other agents in various clinical scenarios, but this is certainly an area where TNF antagonists have the preponderance of data and a lot of real world data also to support their use. Now, in terms of mucosal healing, for those of you who follow this space, I've just mentioned that we used to rely a lot on symptoms. We've now realized our symptom scores are not great, especially in Crohn's disease. There's lots of data that tells us patients with IBS can actually score much higher on our symptom scores than patients with IBD. And so people have really looked towards more objective markers of healing. And one of the things we think about is actually looking at the bowel to make sure those ulcers have actually healed. So this would be analogous to a dermatologist looking at the skin to see if the psoriasis plaques have disappeared. And so we often do rely on endoscopic assessment. Now, this is problematic if patients have disease that we can't reach with a scope, like isolated small bowel disease. But our clinical practice guidelines, we have something called STRIDE guidelines, which tells what to target in clinical practice, really says healing of these ulcers should be our ultimate goal in these patients with IBD. So in terms of data, again, we're starting to see in the pivotal studies, so all of our older agents, so infliximab, adalimumab, most of our agents that have been approved to date were approved based on symptoms, which in some ways is kind of horrifying when we see how poorly symptom indices actually perform. However, there are lots of data, and this is a randomized control data. This is actually one of my favorite IBD studies. It's called the EXTEND study. And this was one of the first studies that actually looked at mucosal healing. So they took patients with active disease and randomized them to adalimumab or placebo. And this was one of the first studies that showed healing of the mucosa can actually occur. Now, this seems like such a no-brainer study today, but at the time it was actually conducted, people weren't looking for mucosal healing. They were basing it on symptoms. And interestingly, the definition they used in this study was not based on all the fancy indices that we have available today. It was based on absence of ulceration. And the field had kind of moved away from absence of ulceration to these fancy indices. And now STRIDE has actually suggested absence of ulceration may actually be an appropriate endpoint. So this study was actually really visionary. It was done years ago. People didn't really even talk about it for a good 10 years because it wasn't something that we were doing in clinical practice. And it's kind of come back again, and it's very topical. Based on how we're actually practicing today. So this is one line of evidence. There's lots of other studies and lots of other real world data, but certainly if we're looking for mucosal healing, the strongest data really are still with TNF antagonists. With our newer biologics, so Entyvio and ustekinumab, we have weaker lines of data suggesting mucosal healing, but I will highlight any drug that comes out from here onwards. So risankizumab, which will be our first drug approved in Crohn's disease since the Health Canada, FDA, and EMA changed their criteria. We're going to start seeing that mucosal healing data even in the pivotal studies. So this is an area, I guess, where we would say TNF still have the strongest data for now, but we're going to start seeing the newer agents. We're going to have this data available to us right at the time of launch. So we'll see a shift in the field. Still, though, we do know that this is, there are strong RCT data that these molecules can still heal the bowel. What about pregnancy? So pregnancy is always a very delicate area. I think this is an area that's so important for the mom and for the baby. We know that IBD itself, having IBD itself, doesn't necessarily affect pregnancy outcomes. But what we do know is that patients with active disease do much poorer in terms of their pregnancies. So patients with active disease, we certainly know they are much higher risk of preterm losses, small for gestational weight babies, lots of issues. And so this is a time that's really important for both maternal and fetal health. And so what you'll often hear this rule of a third. People will say that during pregnancy, a third of women flare, a third will stay the same, and a third get better. That's true if you take all comers. Patients who start in remission actually have a 75% chance of staying in remission. And so having someone in remission at the time of conception is the most important thing that we can possibly do. And what about our therapies? Well, most of our therapies are not tested during pregnancy. We would consider that unethical to experiment on pregnant ladies. And so most of what we've learned has really come from real world experience. And that's either because people have become pregnant without intending to, or because their disease was so severe that there was no choice but to continuing it. Of all of the agents we use, certainly methotrexate is absolutely contraindicated. It's embryo lethal. What do we know about our biologic drugs? All of the biologics we use in the IBD space to date are IgG1 monoclonal antibodies, so they absolutely cross the placenta. We know in the first 2 trimesters, it's a passive transport. In the 3rd trimester, it's an active transport, meaning the fetus has higher concentrations than the mom. So there was a lot of and so at a certain point, I think people were recommending discontinuation of therapy. With time, we've gained so much data. So this is based on one registry. There's so much data based on these drugs are used in 9 diseases that typically affect women of childbearing ages. And so with time, we've seen many, many babies born on biologic drugs, and there really does not seem to be any risk of congenital abnormality with the TNF antagonist. So certainly no risk of congenital abnormalities. There's a small signal for possible neonatal, infant infection. And so that's something that we certainly keep in mind. So I think most guidelines now do recommend continuing the TNF antagonist. Up until recently, the European guidelines suggested stopping at week 24. The Canadian guidelines say to continue dosing throughout pregnancy and just making sure the mother delivers at trough. I think those guidelines are now coming together and I think are much more consistent with Canadian. And so certainly there's many different analyses that have actually happened over many years. And so we have lots of data from many different diseases, which again suggest that these agents can be continued during pregnancy and even during lactation. And so it's important also to remember the risk of flaring is based, we think is dependent on HLA, the mom and baby's HLA type, so much more likely to occur if mom and baby are HLA compatible, less likely to occur if they're HLA mismatched, and we don't have access to that. So every pregnancy can be very different. So a lot of times people say, oh, I was fine in my last pregnancy, it'll be okay. We don't know that for sure because every pregnancy is going to be very different. Certainly, there's lots of data from real world experience and many babies. And some of these babies now are older. They're actually teenagers now. And so we've even seen the long-term sequelae of being exposed of neonatal exposure to TNF antagonists. So lots of data. And in Canada, the only drug that actually has pregnancy listed in the monograph, not to say that it's safe, but that there are data in pregnancy, is adalimumab. So Humira, to be specific, has it listed in the product monograph. So if we're looking at preponderance of data, certainly with the TNF antagonist, having said that, I think there's lots of people who've had babies on some of these other agents. And I think overall, we think all of our biologics are fairly safe to be continued during pregnancy. And the overall consensus always is that the health of the mom is, we think, really important to the health of the overall pregnancy. And so the risk of the drug is outweighed by the risk of a potential flare. The other last area that I think I'm going to focus in on is really the young or pediatric patient. Again, there are lots of data, and there are data from RCTs to support the use of infliximab and adalimumab in the pediatric population. Very often, our other biologics take a lot longer to get approved, and they're sometimes used off-label by extrapolation. But in terms of dedicated data, certainly, and approvals, I think TNF antagonists have been used probably for the longest time, and certainly have data to be used in this very young population. The young population is very unique because they are still growing. We worry about growth curves. We worry about fusing of end plates in their bones, and they have the potential for very long exposure to a drug. So I think they are a very unique population, and regulatory bodies typically evaluate their data separate from the adult data and don't necessarily allow extrapolation. So there are data to support, again, in this also vulnerable population. This was the slide that I had alluded to earlier. So why is time on market an important thing? Because this is how we actually learn about drugs. So drugs are usually developed by looking at healthy volunteers. Then we look at really selected patients, and then we actually have launch of the drug. So the selected patients are in a randomized control trial. And then with time, we start gaining all sorts of information. People, we see what rare side effects are. People start expanding outside of those trial criteria and using the drug in other patients. We see what happens in pregnancy. Sometimes we learn more about what happens with inadvertent exposures. And so we learn a lot about drugs over time. And so with the TNF antagonist, just based on the fact that we've been around for 20 years in IBD, we always have more data with TNFs than any of the newer agents, just by virtue of this time log. And so that's why I think some clinicians and some patients still gravitate to these agents because of their familiarity with this time on market. And I did lie. I said that was my last group, but it wasn't. But where I'm just going to quickly focus on extraintestinal manifestations. We know IBD is really a systemic disease and can affect so many different organs through organ systems throughout the body. And so I really, we very often want to be able to co-manage. Now, some of these EIMs we call parallel or congruent, meaning that if you treat the disease in the bowel, the rest will fade away. Some of them lead a very independent course, like pyoderma gangrenosum, or we also know that there are this risk of IMED. So if you have one immune-mediated disease, you're much more likely, people will say 7 to 11% times more likely to have a second immune disease. And so TNF antagonists have broad indications in 9 different diseases. And so very often in my patients with concomitant ankylosing spondylitis or pyoderma, this is a therapy that we can often cover 2 diseases with one agent. Just as a reminder, EIMs are actually very common. So these extraintestinal manifestations are very, very common, and the majority actually occur with time. They may not be there at the time of actual diagnosis. And this is just to remind us that these extraintestinal manifestations actually sometimes cause more burden and more problems with quality of life for patients than their actual IBD. So the joint pains are often what people worry about more. Pyoderma, uveitis. These things are what actually impact patient quality of life much more so than their bowel disease. And we know that TNF antagonists are very beneficial in many of our extraintestinal manifestations, uveitis, arthritis, many different diseases. And so this is just a reminder, in Canada, these agents are approved in several different disease states. And so if you do have patients with many different diseases, you can sometimes cover both with the same molecule. So I think at the end of the day, with TNF antagonists, it is a path that is very well traveled. I think that we have certain areas where they clearly have very strong data. Now, I have a very unique practice where I tend to see patients are a bit more refractory. And so I certainly welcome as many new agents to clinic. I still every day see people that we have nothing to offer. And so I do think the new agents have huge offer these new new opportunities and windows and have very strong, compelling reasons for use. So it's not to say that the new agents shouldn't be used. I use them a fair bit. I do think, though, all of our agents have a spot in our clinic, and I think we all know patients that would benefit from all of our agents. I think there are certain places where TNF antagonists are still my go-to, just because that's what the data support. And well, as we gain more data with newer agents, we may move away from that. But I do think the newer agents also bring a lot of advantages. And so really it's a decision based on your patient characteristics and based on that conversation. But certainly TNF antagonists certainly still have a role in my practice. So I think that's all I'm going to say for today, but I wanted to save some time for any questions and to be able to chat with you. So I'm really happy to take any questions if there are any.
Firstly, I just want to thank you very much, Rena. That was an amazing talk, and it is amazing as an older physician. I mean, back in the days when I was going through it, we basically had prednisone and Imuran, and now we seem to have almost an embarrassment of riches in a sense. But I mean, really, when I look at it, and you mentioned it yourself, there's a lot of refractory patients that were sort of left. Still, we've tried a number of different therapeutics and have not been able to really help them as much as we would have liked. And so I know you don't have a crystal ball, but I mean, back in the day, we were hoping for a cure. We're still seeing, even with, and there's a question in the chat about Skyrizi, even there, I mean, you would know the study more than I would, but the response rates are still not 90%, right? Like they're still far from where we would like to see things. So any comment on that of how we can push things to get a response rate almost of 100%, let's say like in hepatitis C and hepatitis B and so on?
Yeah, we're so jealous of the hepatologists. We're like stuck at these 50. So it depends on the study, but we see these 30 to 50% response remission rates. That doesn't include endoscopy sometimes. And so you're absolutely right. I think it's been suboptimal, our current therapies. They've been tremendous and revolutionized the field, but certainly suboptimal in terms of where we would like to be. And so I think many people in the field have said this current wave, there's so much excitement around Skyrizi and so much excitement around this upadacitinib. And so many people, I think, have said if these two molecules do not break the efficacy barriers in IBD, probably our next step is going to be these combination biologics. We hear about this a lot, that maybe we need 2 drugs or 3 drugs in order to get the efficacy rates where they actually need to be and to help. One of the issues we have in IBD is there's so many pathways that we think when we inhibit a few, we just activate new ones. And so we maybe need to inhibit many of them to get the disease back into remission, and then we'll need to learn if that's safe, and then if we can start peeling away biologics. I will say Skyrizi, the numbers don't look great. However, no, they do look great. I'm sorry, I'm not saying that right. The numbers do look great. Maybe not that 70-80% that we were hoping, but this is the endpoints are extremely hard. So just as a trialist, I can say they do week 12 endoscopy, and none of us in clinical practice would probably scope a Crohn's patient at week 12, and an extremely refractory. So there's most of these patients were bioexposed, some of them to like 3 or 4 biologics. So even to get those types of efficacy rates in this recalcitrant population, I think says something. And so how that would work in a bio-naive is, we don't know. But I will say, so when you look at the upadacitinib data, in the maintenance phase, we see endoscopic healing rates of upwards of 70%. So we're actually getting close to that efficacy barrier that we talked about. So if the safety profile of upadacitinib is as they predicted should be, that one has the potential to be transformational. So I do think there's a lot of hope in the IBD space, but if these agents don't get us there, then I think it's going to be, certainly if we don't get there, then I think it'll be combination therapies.
Dr. Hassami has a question. Go ahead.
Sorry, thanks, Dr. Khanna. It was amazing. And I'm a dermatologist in, kind of Scarborough General Hospital and community practice. And just feedbacks like Skyrizi for us was as you said, it's amazing. Like we get even up to 100% of skin clearance, and it really doesn't need monitoring. It's one of the safest and one of the best things, like the class of anti-IL-23. But I heard that the dose of Skyrizi or risankizumab in GI is quite high, much higher. So I'm just curious, what dose? Because you said probably the next gonna be December 12. Are you aware of like the dose that is? Yeah. Because for example, for ustekinumab for Stelara, our dose is much lower. You give like a good loading dose IV, which is not the dose we generally use. So I'm just curious that what dose. And I have one more question later, if it's okay.
Sure. Yeah. So we use industrial dosing, we often say in IBD, just because the disease is so refractory. So our dose for Skyrizi that was approved by Health Canada is a 600 milligram IV.
Medical oncology consultation.
Sorry.
Next paragraph, reason for referral, colon, next line.
Sorry, so there's there'll be
liver metastasis. Next paragraph.
Sorry, I think one person is also dictating that ABGIN.
Oncologic history, colon, next line.
Sorry, so 600 milligrams
gastric cancer treated with radiation in 2020.
And then following
Sunnybrook period.
3 doses, it's going to be a 360 milligrams subcutaneous every 8 weeks. And so that dose is so high that it cannot actually be given by a subcutaneous injection. It's going to be given by something called an on-body injector. So it's like this little thing shaped on the size of a credit card, thicker, that will be stuck to the patient's skin. They push a button and it'll infuse over into their system over 5 minutes because the dose
apparently also lung mass.
Sorry, so you said 600
biopsy.
600 loading dose and 360 through that system. Is that right?
Yes.
And my other question, like emphysema. In dermatology, we basically don't stop biologics.
Emphysematous
surgeries.
Period.
Do you recommend or do you advise to stop biologics before your surgical thing?
Yeah, so typically speaking, most of our data, and it's not great data.
CT scan, chest/abdomen, and pelvis, October 5.
There is risk associated with continuing the biologic. I will say that in certain surgeries, particularly orthopedic surgeries or neurosurgical ones,
early October.
I still prefer that we hold a dose, and so often we'll still defer to the surgeon's opinion. If they feel that it's necessary, then we're not necessarily opposed to it. Our general surgeons are usually pretty comfortable with them staying on.
Not a candidate for systemic therapy, period.
Are you worried that they won't have the same response after, when you start them back on biologics, like especially in the case of Remicade or Humira anti-TNF, like drug antibodies?
You're right. Absolutely. It's always a concern. And so if it's going to be stopped, we want to minimize that period of exposure. Having said that, I think if patients miss a single dose or
early October suggested liver metastasis, period.
Usually, in truth, we wonder because it's still going to be systemically circulating drugs. So you wonder if
was awaiting further outpatient
if necessary
workup with MRI, period. Next paragraph.
If necessary to do that,
past
then
medical history, colon, next line.
Missing a single dose or so is usually not so problematic for antibody development.
I see Grant.
Anemia, next line. Chronic pain, next line. COPD.
As a question as well.
With multiple admissions for this.
This ABGM clinic to please mute, but they haven't muted yet.
Next line.
Sorry, I apologize.
GERD, next line. Hypertension.
Grant?
Yes, hi. Rita, great talk. I'm glad you did abandon anti-TNFs because I think they still have still a
treated with
role.
SBRT August 2022.
Moving away from them because we have all these other wonderfully better, stork targeted agents that are safer. Certainly, I still, beyond the specific indications you pointed out in terms of the evidence, fistulizing disease, pregnancy, post-op, I still lean towards it the sicker the patient is. I don't know if how you position it, but certainly I still have a preference for anti-TNF.
RUL.
Are on the sicker end of the spectrum as opposed to a little more moderate and a less severe end, so to speak. where I think I still feel more comfortable, and I feel, even though rightly or wrongly, I still feel that there's probably a little bit more bang just to
Next
have
paragraph.
a broader
Medications, colon, next line.
Yeah, you're absolutely right. And I
Reviewed
think
on chart, next
lots of
paragraph.
things for that. I think
NKDA, next
part of that
paragraph.
is just
Social
related to
history,
the
colon,
fact
next
that
line.
we use this.
Lives
these
alone,
numbers
comma,
to
supportive daughter,
hospitalize,
period.
like, here you see patients. So
Heavy
certainly
smoking
we would
history,
think some of
period.
that might extrapolate.
No
over
ETOH abuse, period,
ambulatory
next paragraph.
And I think with
Family
something
history, colon, next line.
for example, we've learned a lot more about TDM levels and how to dose
Unclear.
optimize and how to
Comma,
superload
patient
our
not
patients that are
forthcoming.
very, very sick. So you're absolutely
Next
right.
paragraph.
Caveat I will put in, and again, this is not ready for prime time. It's just food for thought. We have seen with the upadacitinib in UC.
History of presenting illness, colon, next line. This patient has been admitted with
based on their
failure
pivotal
to thrive,
study,
period.
they're
He had
suggesting
generalized
that there could be
weakness
efficacy as early as day one. Day
and
one,
unable to transfer
so if
from
that
scooter to bed,
translates to
period.
our clinical practices, it may be another agent.
He also
that's
complained of
great
generalized
onset. They actually even
body
prevent
pain, period.
in theory.
He had worsening
You
cough
can
and
give them like
dyspnea,
a
period.
sample, like if you can give them a first
Next
pill
paragraph.
or better by day one, that would be incredible. That remains to be proven. It was just a post hoc analysis of their pivotal data. But I agree. I think in the sickest patient, the data still really support a TNF antagonist.
I have two other questions. One is, I think my feeling is that to break that therapeutic ceiling that Gord was talking about with model therapy, I think combination therapy is probably the way to go. Ideally, obviously, some future down the road where we could actually do a test
on home oxygen.
This particular patient's disease is driven by this particular mechanism of action. Without that, I think combination therapy is probably the way to go. Have you had experience using that, and what sort of patients have you used it in?
Yeah, I have. I've used it in a few, so it's completely off label for anyone that's listening. But it is completely off label. I've either done it in patients who have very limited options, like so they either have had like marginal response to a couple of biologics but are still too sick, or in people who have two comorbid conditions where we actually so very often the problem mainly has been around coverage, and so often if the rheumatologist or dermatologist can get coverage for one and then we get coverage for the other. Typically, when we use it, we try to use vedolizumab as our base drug, and then the other specialist uses something systemically acting so that we're not combining two systemic immunosuppressant agents. Having said that, one of my niche populations that I treat here in London is the post-transplant patient. So these patients are super immunocompromised because they're on their 3 transplant drugs, and then I often add in like infliximab or Stelara or something. So I think sometimes, I don't know if there shouldn't be toxicity of combining two biologic drugs that we have access to right now, because they are not hepatically or renally cleared and are not stored in adipose tissue. So it should actually not be an issue. We just don't have data necessarily to support that. There are a couple of combination studies being done right now. So down the road, we will have some answers to the safety and efficacy, but to date, they're based on all the case series, case reports, and the trials that we've seen read out, it seems like a reasonable approach. I think most people pick Vedo though as our base just to minimize immunosuppression.
Okay. The last question is in regards to Skyrizi and how you are planning on using it. Do you think it'll replace Stelara in the armamentarium, given the mechanism of action, given the efficacy in not only IBD, but psoriasis? And maybe Lori can comment on, I don't know if the dermatologists have sort of wholesale moved over. So I'm curious to know, because because of its mechanism of action and the fact that it seems to be pretty good.
So I think all of our drugs will have a role for sure. I do think Skyrizi, if the data pan out to be as good as they're showing, it seems to work in our bio-failures, bio-naives, it does have the potential to really be a game changer, blockbuster drug in our space. Not derm version or hepatology version, but our version it does. And I think it'll come down to what the safety looks like. There's no data to suggest that we're very risk averse actually in IBD, which is very interesting. I think TOFA has taken off in other areas. We're very hesitant in IBD. So I think it'll come down to what that looks like. I think one of the things, particularly in Ontario, is ustekinumab is actually not on formulary with EAP. And so we're relying on it compassionately.
Next line.
that's going to look like long-term, I'm not really sure. And we certainly know from the trials that Skyrizi seems to even work in USTA failure.
His chest imaging
Interesting.
suggests
Mechanisms
multifocal
overlap, but
pneumonia
clearly don't overlap
and severe
enough, that they
emphysema
aren't
period.
independent. So if they are still behaving independently, I think there will be some patients that
COVID test
benefit from one
is
or the
negative
other.
period.
So I think they both will
He
have
is
a role,
on
but certainly
antibiotics,
I think has the potential to
also
become
seen by Respirology and
one of
on
our dominant players in the field.
puffers plus prednisone period.
Thank you.
All right, I think we're just actually 1 minute over time. Thank you very much, Rena. Awesome.
Next line.
I'm sure we'll see you in person or at virtually at future meetings.
He has been
So thanks again.